example myself. But this is our last true week of instruction. Exciting. So we'll wrap up chapter 44 today. In the cardiopulmonary A&P class, we'll do chapter 12. Wednesday, we do chapter 17 in that class. Also Wednesday, the folks from the FSRC are going to come out and talk. They're going to come out and talk to us during our fundamentals class time. Not that they need 2 hours, but I want to give them plenty of time to cover what they want to cover. Tuesday, we have the last chapter to talk about in the patient assessment class. And then next week's Thanksgiving. Again, you guys have gotten a reprieve from me for next week. You guys are out here on Tuesday, however, with Desmond, right? Taking the test? Okay, so taking the test there. The week we come back after Thanksgiving, that Monday will be a review for the fundamentals and cardiopulmonary A&P finals. That will be Wednesday. You've already heard me say it, but I'll say it again. 50% of the final exam is coming from, in this class, chapters 43 and 44. In the cardiopulmonary A&P class, 50% of that final comes from chapters 12 that we're talking about today and 17 that we're talking about Wednesday. So that gives you, I know from me anyways, you have a breather Thanksgiving week, but maybe when you have a moment or two, you may want to review that stuff. That way, when I do the final exam review on Monday, I'm not talking about anything from chapters 43 and 44, and I'm not talking about anything from the cardiopulmonary A&P class, chapters 12 or 17. That's what we're talking about this week, or we started last week. It'll be all this stuff earlier from the semester. Things that at one point you knew. It's just bringing it back to the front, hopefully, of your brain to remember, hey, don't forget to look at this. Don't forget to review that. So it won't be the entire classes from day one, but those helpful hints, again, for the other 50% of that final, things that if I were you, I'd look back at. And folks will ask me too, John, there was in that cardiopulmonary A&P class, there was quite a bit of math in that certain section of the semester, right? How many of those are we going to have to know? I'll give you that information on that particular date to kind of narrow your focus somewhat. But like I said, prior to that date, in this class, at least have chapters 43 and 44 under your belt where you feel comfortable with that. And in cardiopulmonary A&P, that chapters 12 and 17, you're comfortable with that already. So the stuff you're reviewing or cramming in, whatever you want to call it, is stuff that you did study before, something you did have to know before. It's just bringing it back to the forefront. All right, so chapter 44, just part 2. This is the last half. It's not exceptionally lengthy if anybody happened to look at the PowerPoint. So I'll be more than happy to answer any questions as we go through if anything's not clear. Also, this Friday, there is our last lab. That's going to be over the stuff we talked about in 43 and then the stuff we've discussed or will be discussing from chapter 44, including all of the equipment, all of the devices. We have every one of these, for the most part, things that we will have or will be discussing from chapters 43 and 44 in our own lab, so you guys have an opportunity to sit there and get a little hands-on experience with it. Anyways, part 1. What do we talk about in airway clearance? What was the therapy we really spent that whole time talking about? CPT, which stands for chest physio or chest physical therapy. Talking about manual, what's that word called? Manual percussion, the cupping of the fingers, cupping of the hands, applying a rhythmic motion to the chest or back to create that vibrational energy. So if I have someone with secretions, do I just walk up into their room and start pounding on their chest? No, what's something I could do to assist with that? Positioning or postural drainage. So don't forget about those postural drainage positions. But what if the patient doesn't tolerate that? We can't put them head down. They won't tolerate. The second I get a couple of these in, they're like, ow, ow, that really, really hurts. I've had surgery, I've had a broken rib, I've had this, I've had that. I can't handle that. Is there something else we can teach them? We can teach them some of those coughing techniques. But again, if I'm trying to loosen mucus, maybe I could use some of the therapies we'll talk about here today. All right, so first one, manual assisted coughing. Manual assisted coughing. So best with patients with neuromuscular conditions. Neuromuscular disease may benefit from this sort of airway clearance therapy. We will assist them generate a forceful expiration because with their disease or their disease process, they might not be able to generate adequate expiratory flow and adequate expiratory cough to remove mucus. 3 options here for manual assisted coughing with airway clearance. Number 1, we can intubate, put an artificial airway, and then get a suction catheter and go in and remove the secretions. That's a legitimate way. That could be one reason we need to intubate a patient, to help them control their own secretions. Okay, that's one way. We don't like to have to do it that way. If we intubate somebody, typically it's because we have to put them on a ventilator or a breathing machine. In this example, it would be just for airway clearance. Okay, we don't like to do that unless we absolutely have to. Number 2, this manual assisted coughing. We can actually assist them generate a cough. And then the last one is the MIE, which we'll talk about that piece of equipment in just a second, the mechanical insufflator exsufflator, and we'll talk about that in just a minute. All right, so this first one, the manual assisted coughing, sometimes folks will call it quad coughing. These are patients who just cannot generate adequate expiratory flows and can't generate an adequate cough. It gets the term quad coughing because this could be perhaps a quadriplegic patient, a paralyzed patient who still can breathe on their own without ventilatory assistance, but they just need assistance in getting their diaphragm to actually move and generate enough force to cough. And so you can tell by the pictures here, we actually have our hands on the patient's diaphragm, either directly up underneath that epigastric area or on either side. And we do what with their diaphragm? We actually move it up to assist them with coughing. And so you could have your hands on the patient's diaphragm on either side. Tell them, as best you can, take a nice, slow, big, deep breath in. And you could feel their diaphragm move. And then make sure they're aware. This is not a surprise to them. All right, do a couple more big breaths for me. All right, after this third one, we're going to cough. And you're going to literally force their diaphragm up. But again, like I said, no surprise. You let them know, okay, one more breath. All right, the next one, I'm pushing. And you give them that assistance. Now, be mindful of the position you are in when they cough, right? I'm dodging here because I don't want them coughing right in my face. So be prepared what you're about to do. No surprises if you're eye to eye that, hey, something may be coming your way. So you may want to avoid or remind the patient, hey, you go that way, I'll go this way. So you're not getting anything thrown into your face. And again, open hand pushing. This is not a punch. I'm not throwing an uppercut up into their diaphragm. I will literally help push and force that up. Now, again, speaking for myself, the first couple of times, I don't want to be overly forceful. I want to assist and let the patient know, okay, need a little bit more oomph? Yes, and you're going to have to do a little bit harder. Okay, I'd rather start soft and build up instead of going way too hard at first. And so it may take a couple of tries, may take several breaths, may take a break in between, but assisting that patient with their own, be able to generate their own cough. All right, the mechanical insufflator exsufflator, abbreviated MIE. Again, I always try to warn you guys because who knows when you guys take your board exam what the NBRC is going to call this type of device. I have seen them just simply use MIE instead of writing it out, mechanical insufflator exsufflator. You may hear this called the cough assist device. That's a brand name, cough assist. It's what they typically call it in the hospital. Again, brand name. It's the same thing. It's a mechanical insufflator exsufflator. Best used for patients with neuromuscular disease. That's my abbreviation up there, NMDs, neuromuscular disease. Whether it's multiple sclerosis, muscular dystrophy, ALS, Lou Gehrig's disease, and there's several others, and we'll get into some other examples in due time. But assisting the patient, all right? This helps the patient generate expiratory flow so they can generate enough effort and enough flow to get mucus out. Now, again, giving you some numbers here, so be mindful of the number. So, the American Association for Respiratory Care recommends peak cough flows that are not at least 270 liters a minute to be recommended to have MIE. You and I, just for comparison, probably can generate anywhere from 400 to 1,000 plus liters of expiratory flow when we really bear down and try to cough. So if we can't generate at least 270 liters, this may be a device that would be appropriate. Again, if the patient can't do this, and I'm giving them great CPT and chest percussion, that's all good and all, but can they generate enough oomph to cough and clear? I don't do them any good by getting everything loose into the central airway, and then they don't have enough force or power to expectorate or cough that stuff out. And yes, I could potentially go down with a suction catheter and help clear the rest of that stuff out. So how this works, it provides mechanical insufflation and exsufflation, hence the name of the device. So it provides an inspiratory pressure, a significant amount of inspiratory pressure. Do you remember when we talked about IPPB for hyperinflation therapy? And I said, okay, the greater the pressure you give them, the greater the volume of air they're going to pull in. But I said, make a note, we're never going to go higher than a certain number. Does anybody remember what that certain number is for IPPB?
It was 20.
It was 20 centimeters of water. And I said, oh, if we're given IPPB and we go above that, there's a potential even for you and I with healthy lungs that we could perhaps pop the lungs. So be mindful, don't let the pressure in IPPB go above 20. What about with this therapy? That's significant. That's a lot of pressure. Apply to the airway for 1 to 3 seconds. This could be given via a face mask, like an ambu type mask. Could be a tracheostomy tube. Could even be a mouthpiece or down an ET tube. So this positive pressure breath. And that's going to force them to do what? Take in a big, massive breath. Big volume of air with all this pressure we're forcing into the lung. And then guess what immediately happens?
They cough it up.
The pressure reverses. Unlike IPPB, where you give a pressure, say maximum of 20, and then as soon as that pressure is reached, that positive pressure goes away back to 0, and the natural recoil of the lung allows for exhalation. Well, for exhalation, guess what happens to that positive pressure? It reverses. It doesn't go from 30 to 50 to 0. It goes from 30 to 50 to negative 30 to 50. So you know what it does as far as expiratory flows? It actually is sucking and pulling that breath out, hopefully with mucus with it. All right, followed by another positive pressure breath, followed by that pull of that negative vacuum pressure. So similar to IPPB, at least on the inspiratory portion, but greater pressure, but a complete reverse of that pressure, a pull of that pressure, trying to pull that expiratory flow, pull that air, and in turn, pull that mucus out with it. If you were to look on the device itself, you can even program it. Well, how much time do you want that expiratory pressure? What specific expiratory pressure would you like this to be? Inspiratory pressure, well, how much pressure? How long for this inspiratory pressure? So I know I gave you some ranges here, 1 to 3 seconds, 2 to 3 seconds. We can fine tune that for each individual patient, what works best for them. All right, but you can control that. How much time they're gonna spend inspiring, how much time they're gonna spend expiring. Those times don't have to be the same. They could be different. Those pressures don't have to be the same. They could be different, just depending what we're trying to achieve. And you can even give a kind of a pause in between inspiration and expiration. There's your example of a breath hold, if you wanted to add that. And most of the times we do a very brief kind of pause, but make sure the patient is aware, yeah, you're going to get that big breath, and I'm going to turn around and I'm going to take that breath right out of your lungs, right out of your chest. And yes, it's not uncommon, it's quite common for mucus to start really kind of flowing. So you have to be kind of ready with maybe a Yankauer suction catheter or something like that to help kind of clean up any excess that's there. Any questions on the mechanical insufflator, exsufflator? It is a cough machine. And whether the patient can adequately cough or not, guess what they're going to do when they're wearing one of these? They will cough. They will cough. They will get that big breath in, and that air will immediately get pulled right back out, after whatever amount of pause you may have put in that device. So it's a very good device. You don't see it every place, unfortunately. You'll see some of this stuff in your travels and clinicals, whether it's next semester or semester after. You will see these things used, but just be aware, not every place has them. Not every place uses the different devices we'll be talking about today. All right, positive airway pressure adjuncts. All right, so there's a lot of these. They go by different names. They're all fundamentally the same. How they function is the same, but like the DPIs and the various type of DPIs, yeah, they're all about the same, but how you activate them, how you use them, how they function can be a little bit different, the uniqueness of each device. All right, so these are used to mobilize secretions, can be used to treat atelectasis. Positive airway pressure, we mentioned this a little bit with lung expansion therapy, can be used to treat atelectasis, but more so, we're looking to remove mucus. Maybe the reason this patient has atelectasis is because mucus is accumulating, mucus is plugging the airway, and that's what's leading to the patient's atelectasis. They can be used in combination with other airway clearance therapies, including coughing, of course. So sometimes these could be used. Many times they don't need a power source. Like, for example, the mechanical insufflator, exsufflator needs electricity to run. So I consider that not very portable. Yeah, I can bring it with me to places, but it's a larger piece of equipment. It does require a circuit, the mask, or the connectors in my trach, if that's the case. So I don't consider that quite as portable as maybe some of these positive airway pressure adjuncts. With positive airway pressure, because of the need to remove secretions and generate some back pressure, usually you see these performed during exhalation, and so hence the name PEP, positive expiratory pressure. So PEP is a type of PAP therapy. Sorry for all the initials here, but positive airway pressure, PEP therapy. Again, and it tells you when the therapy is going to be performed during exhalation, when the patient's expiring. Sometimes it could just be PEP therapy they're receiving, just this positive pressure. Other times it could be a combination of not only PEP therapy, but this PEP therapy that vibrates or oscillates, meaning that pressure is changing as it goes through the airway. All of these devices, I consider it a form of CPT, but it's CPT from the inside. Okay, once you see the devices and see how they operate, it'll make sense to you. Plus, I'm excited to say Friday in our respective labs, now we don't have enough for everybody, but we will be soliciting some volunteers on Friday that you're going to need to demonstrate and try this stuff, okay? And we want to share the wealth, so we don't want the same person volunteering every time. So if anybody has a chest cold or a little congestion, you need some assistance, maybe that's my volunteer come Friday to see if we can get some stuff moving in your chest. All right, so these PEP devices, they have either fixed meaning I can't change it, or variable, meaning I can change it, expiratory flow resistors to generate this expiratory pressure. Now, the pressure typically applied is somewhere between 10 and 20 centimeters of water. That could either be a fixed pressure, or a variable pressure. And I'll show you how you can change some of these that are variable as the patient exhales through the device. So if we're using PEP therapy, and here's my mucus plug, we can use those collateral channels of ventilation to build up some pressure in those alveoli that are blocked to now have some volume in here that now the patient could exhale against to kind of blast and clear that mucus out. So that's PEP therapy alone. If it's PEP therapy that has vibration or oscillation, not only do you still get the pressure buildup, but now that pressure could oscillate inside the airway. Again, it's the same thing that this creates, oscillating or vibratory energy, but it creates it from the inside. Because again, the patient's feeling this as they exhale through the device. Studies have shown PEP therapy to be as effective as other airway clearance therapies. And that's nice because the PEP therapy device doesn't tire like you and I would tire doing manual CPT over time. Valuable that they can be self-administering. I can instruct the patient the first time and then turn it over to the patient and say, hey, do it at your leisure as you feel comfortable in performing it, but I still need you to perform it. And they don't necessarily have to have me. They can go home and still use this stuff. They could use it on the car ride leaving the hospital going home and still get the benefit of this therapy. Now, it can't be used by young children, typically under the age of 3, just from lack of quality technique. Plus, they might not be able to generate enough expiratory flow or a deep enough breath to make this therapy effective. Now, I know I didn't put it on here, but you could probably, if things are affecting the very young, you could probably say the same thing must affect the very old if they can't take a deep enough breath. Again, my grandma analogy. If she can't take a very deep breath, then this might not work for her. If she can't generate, because again, when is this therapy applied? During exhalation. And if the patient can't exhale for very long, then they're probably not going to get a very good therapy from this. Maybe they need something different. The patient must be able to take a deep breath, greater than 10 to 12 mLs per kilo of their predicted body weight to generate adequate pressures, oscillation, and prolonged exhalations during PEP therapy. All right. Here's a very generic example of the steps in performing PEP therapy. Okay? This is pretty much the same instruction for every single one of these devices I'm about to share with you guys. So I just put all the instructions on one slide, and then we could look at the different devices on the other. So have the patient sit comfortably. I wouldn't prefer them to stand for the potential that maybe they get dizzy, lightheaded, and I don't want anybody passing out or fainting or hitting their head. They should take in a breath that's larger than normal, but not a maximum breath. Okay, larger than normal, big breath in, of course, but not a full, complete maximum breath in. A breath hold if they can. And it doesn't have to be 10 seconds, not like an MDI or DPI. Nice, big, deep breath in, brief breath hold, couple of seconds. Then they will exhale actively, but not forcefully through the device. So they do need to exhale. They will feel resistance as they exhale through the device. They're feeling pressure. They're trying to exhale, and this pressure is kind of preventing them from exhaling. So they will feel this resistance, and I'll make sure they're aware. Yeah, it's not going to feel like you're exhaling normally because there's going to be something kind of blocking your passage of air. But they still need to actively exhale because it's that active exhalation that creates that pressure that their lungs are going to feel. And if it's just PEP therapy, it's just pressure. If it's vibratory or oscillatory PEP therapy, then that pressure will oscillate and vary as they continue to exhale through the device.
So the pressure is created from the device, correct? It's
a combination of them exhaling through the device and then whatever is set on the device that creates that back pressure. Yeah. So it's both patient and device. Their I to E ratio should be, again, a little bit not normal, not 1 to 2 like ours is, generally 1 to 3, 1 to 4, because I really want to emphasize you need to really spend a lot of time exhaling through the device so you get the benefit of the therapy. If they can't exhale for very long, then these devices might not be appropriate. Maybe it's something else we need to try. Have them remove the mask or mouthpiece, do a couple of huff coughs, expectorate if necessary, and then repeat. And continue to go through these steps over and over and over again. Literature says therapy shouldn't exceed 20 minutes. Again, I don't want to exhaust them in doing this. And trust me, those that volunteer on Friday will see what it feels like to actually have some good airway clearance performed. And you can give the rest of the group that didn't get to try that one, your experience. What did it feel like? And whether you have or don't have mucus in your chest, if you did, do you think this would be a good way to kind of clear that stuff out? All right, so here's the 5 different examples that was mentioned in the textbook. And I will say the last 4 you will see in town. Depending on the hospital you're at, you will see these in town. The last 4. The first one, the TheraPep or threshold PEP, is only PEP therapy. You won't feel the vibration or oscillation. It's a strict expiratory pressure only that a patient would feel. Couple different looks or appearances. This one, there's a mouthpiece. Patient will exhale through the device. You will see this little blue piston rise. And I don't know if you can see those 2 lines and those arrows kind of pointing to those lines. When the patient exhales, we want them to exhale to kind of have this little blue piston kind of stick or kind of float in this area. It reminds me of like the incentive spirometer. When you inhale, you want them to use enough flow to keep that little float in the right spot. Same thing here, but this one's an exhalation, not an inhalation. There's an adjustable dial here that can change the resistance. So if it's one of you guys that I know is pretty healthy, you can probably handle more pressure. If it's 88-pound grandmother who's 88 years old, maybe I need to make the pressure not quite as high for her, so she can still feel pressure, but still be able to exhale. You guys, I know, will be able to handle the highest pressure that's there. This threshold PEP, same concept. There's I don't know if you can see, there's a spring in here. This dial, I kind of washed out the picture a little bit. This dial could adjust the tightness of the spring, and if I make the spring really, really tight, it creates more pressure when the patient tries to exhale through it. If it's too much pressure, the patient can't really exhale very well through it, I can loosen it and loosen that spring and make it easier for the patient to exhale through. But it's just, for both of these, it's just expiratory pressure. Just expiratory pressure. That pressure is going to be fixed at whatever level I set it to, or however I tighten up that spring. But it is variable because I can't adjust it. I can change it, making it easier, making it more difficult. All right, the flutter valve. This was really the first type of oscillatory or vibratory PEP therapy. It was the first. It's one that is still out there, but you probably are not going to see this as frequently as some of the others we will discuss. Now, just like, what do you call this in my hand? We call it Kleenex, but this is actually Puffs, okay? So this is Puffs brand. This is not Kleenex, right? The same thing here. These other devices will be mistakenly called the flutter valve, even though this is the one and only flutter valve. So, because it was the first, and I don't know if Kleenex was really the first or not, but it is what it is. This is what a lot of these devices will be just referred to as a flutter valve. Flutter valve's a brand name, and it's this device here. It's actually this thing here. It's actually 4 pieces. There's a section here that you could twist. I don't know if you can see that line. You can actually twist this off, the cover. Inside, there's going to be a circular cone that can be removed. There is a steel ball bearing that gets set down in there, and then the rest of the mouthpiece and the apparatus itself. And so when everything's put together, so obviously inside here is a steel ball bearing. How this device works is, again, instruct a patient, take a generously deep breath, not the fullest breath possible, but a big deep breath. Put this device in your mouth and you will exhale through the device. Now when the patient exhales through the device, their breath is going to go and it's going to cause the steel ball bearing to move. So air can escape. Now when a certain amount of air begins to escape, this steel ball that did become displaced for a half second will fall back down. As the pressure builds up, as you are still, same breath, still exhaling, this ball will move up. Some of your air will escape around, but as soon as the amount lessens, that ball will fall back. This is still your same single exhalation. And so this happens so quickly, again, depending on how the patient exhales. And it creates that vibrational energy that then goes back into the patient's lungs, creating, again, my word here, CPT from the inside. But it does require the patient to do what? Have a long enough exhalation. If they can only exhale for 1 second, then this may move once or twice, and then that's it. This type of therapy is probably not going to benefit that patient if they can only exhale for 1 second. So that's why you want a good deep breath in so you have some volume in your chest, so when you do exhale, you can spend enough time exhaling, causing this steel ball bearing to become displaced. Now, depending on the size of that ball bearing, this resistance that you're feeling, this expiratory pressure, is fixed. I can't change it. Now, you will find some of these that come with different sizes for the steel ball bearing, so that can perhaps change the pressure. Some with larger, some with smaller ball bearings that are not quite as heavy, that would generate a little less pressure. Some that are larger, heavier, that would generate more pressure. So you could potentially fine-tune this for your patient to find the one that's just right. Now, because this was the first one that came out, there are some design features that have been improved in later editions, but they're not the flutter valve. The biggest issue this device had, and again, this is the device, this is what you would hand over to your patient. The biggest issue patients would have is not maintaining the flutter valve in the right position. Now, what's pictured here is the right position. Okay, so this device should be positioned almost parallel to the floor. But patients, and I'm going to use my little clicker here as an example, patients would take it and sometimes turn it up a little bit too high. That would displace this out of the cone, or they would displace it too low, which would move this kind of out of the cone. And so when the patient would exhale through the device, you wouldn't hear the vibration. And so I tell the patient, okay, your exhalation was good, but maybe position this just a little bit. And sometimes, and see what I'm doing here, sometimes have the patient exhale and move it back and forth until they can finally feel what it's supposed to feel like to create that vibrational energy. And again, we can demonstrate the same thing Friday in lab. Turn it up too much, you're not going to hear it oscillate. Turn it down too low, you're not going to hear it oscillate. Find that happy median. Now you'll feel it, and we will be able to hear it as you're performing it correctly. All right, that's the flutter valve. That's the flutter valve. I remember when these things first came out, the supervisor kept them in the office. Why can't it be with the rest of the equipment? Because they're too expensive. At least they were too expensive. They were like $200, $250 when they first came out. And I get it. Everything's expensive. It the math never makes sense to me. Why is this so expensive? Ridiculously expensive. And so the supervisor would keep them in the office. And if we had an order for one of these, we'd have to go say, hey, patient in room such and such, they ordered a flutter valve. Okay, well, here you go. And they would document, all right, the flutter valve's going to so-and-so in room such and such, because they didn't want these things walking out and disappearing. Now, once it's a patient's, it's theirs. It's theirs. And I always make sure I would let the patient know, especially back then when they were $200, $250. Hey, you technically paid for this. You need to take it home with you when you leave here. Don't leave it here because we're going to throw it away in the trash. All right, so that's the flutter valve. That's the flutter valve. It was replaced, the second one was the acapella. It's kind of coincidental, the order here, but the acapella, nothing to do with a musical group or any musical style, But the acapella looks something like this. Now this does not have a steel ball bearing. It is an improved design made by a different manufacturer. So this was competition to the flutter valve. Was significantly cheaper. And so that's when the flutter valve just suddenly, where'd the flutter valve go? Too expensive. 4 parts and pieces to the flutter valve that if a patient was to take it home, yes, you're supposed to clean it regularly. And now I lost one of the pieces, one of the parts. Well, guess what? Now it's not going to work. You know, you have to buy a whole brand new one. The acapella was really kind of one single unit. You could take parts and pieces off to clean it, which was encouraged for patients to make sure you do keep this clean. Here's another thing. The flutter valve, you could not inspire through the flutter valve. You could only exhale through the flutter valve. The acapella, the patient can inhale and exhale through this device. Now, if they inhale through the device, nothing's going to happen other than they're just breathing air in. But the energy they would feel is when they would exhale through the device. There's a little rocking arm on the inside that when the patient exhales, that rocking arm moves back and forth. There's a little magnet in there. It's kind of hard to see, but there's a little magnet in there that does move as the patient's exhaling through. I know it's hard to see on my picture here. You'll see it in person on Friday. I don't know if you can see this arrow and this little plus symbol. You can actually turn the back end of the device, turn it as far as you can to the right. That's going to increase the pressure or increase the resistance the patient would feel. If you turn it the other way, there's a little negative symbol and another arrow on the other side. You turn it far left as far as you can. That's going to lessen the pressure. So again, you could fine tune it for the right patient. You know, for you guys, I say I'm turning it all the way positive. You guys can handle it. But that poor elderly patient barely has enough time to exhale. Maybe I'm going to turn a little more negative for him or her, giving them a chance to exhale. Now I did add this morning, kind of came across. I found a way to create GIFs, and so now I'm spending all my free time going, oh, I need a little GIF of this or a GIF of that. All right, so that rocking arm that's on the inside. So the blue line represents inhalation. The red line represents, or arrows represent exhalation, and this is where they exhale. And that little rocking arm creates that vibratory energy. It is resistance they're exhaling against, but that resistance will vary, will oscillate back and forth. And like I said, the acapella was significantly cheaper than the flutter valve. You could get 4 or 5 of these for every one flutter valve. So it makes sense for the hospital to say, okay, heck with the flutter valve, let's use the acapella. Now there's been some competition over the years with the acapella from some other companies. Aerobica is another device, still provides vibratory PEP therapy or oscillatory PEP therapy. Patient can exhale through this device. Now I don't have a cool GIF or animation here, but when they do exhale, it goes through the housing. There's a little window. We could pop these open on Friday and you can actually see. There's a little flapper that goes back and forth on the inside. There's a little lever here in front that can change the resistance or change the pressure. So it can go on the scale anyways. It says 1 to 5, 5 being more resistance, 1 being less resistance. So you can kind of find a happy median for your patient and be able to perform this device. But they exhale through and then their breath ends up leaving the back end. They can, much like the acapella, they can inspire through this device and the breath would go straight through. But when they exhale, it goes through the housing here of this device. This device is even designed to be connected to a nebulizer, and you could do your inspiration of the inhaled medication and then the vibratory PEP therapy when the patient would exhale. So in theory, kind of killing 2 therapies at one time. You know, they inhale getting the breathing medication, but when they exhale, it goes through this channel creating that PEP or that vibratory PEP therapy.
There are differences in the max pressure in each device, or they're
That's a good question. They're all about the same. They're all about the same level of PEP, which is anywhere from about 10 to 20 centimeters of water pressure. So they're all about the same. And the technique for all of them is still about the same. The only exception I would say is the flutter valve, because you have to have the added knowledge of making sure the patient has it in the right position. The acapella, the aerobica, you could point it this way and perform it, you could point it to the ground and perform it. It's going to still provide that same therapy, unlike the flutter valve that you couldn't have but only in one position. All right, so acapella is at a few of our hospitals. The aerobica is at a few of our hospitals. And I will say this, most hospitals would select one versus the other. Usually don't have two. If they did have multiple versions of these things because they're all doing the same thing, then it would be therapist personal preference on which one you grab to go give your patient. Oh, we're out of the acapella, I'll grab the aerobica this time. You know, maybe if a patient has done one of these previously and is comfortable with one, then I would probably say, well, here, you're comfortable with this, so this is the one I'll give you. But generally, depending on the hospital, you're going to see this one, or you're going to see this one, or the latest, the VibraPep. Looks like somebody said it's like a trumpet. I guess so, yeah, a little handle, and you blow your horn here. VibraPep, brand name, still oscillatory pep therapy. Now, inside the VibraPep, there is a silicone sleeve. A silicone sleeve that when the patient exhales and their breath goes through the silicone sleeve, the sleeve bounces back and forth inside this channel, and that creates the vibratory pep therapy that the patient's feeling. There is an adjustable dial here that you can change the level of pressure that the patient would feel, but this is how that device works, the VibraPep. And I know some places have moved from one of these and they use VibraPep. I don't think there's any literature, at least that I'm aware of, that says one is superior to the other. I think they all work about the same. I think for our hospitals, they typically pick the one that is what?
The cheapest.
Probably the one that's the cheapest. I want to give them the best deal. You know, oh, we make this plus we make this other thing, we'll give you a deal on both of them. Okay, well then we're going to now use this one. But again, I have no complaints over any of them. They all work about the same. All right, any questions?
Is it just pulled out like on the bottom there like that, just to show like what it is? Or
Yes,
do you,
yes.
like,
This
pull it out
piece
from
is
the-
on the inside.
So you don't like take it apart?
For cleaning.
Oh.
For cleaning. And like I said, Friday you'll see this. We'll have some that we can get a volunteer to perform, and then we'll have another one that we can take apart that you haven't exhaled through. Another one that you can take apart, you can kind of see the parts and pieces and how they kind of all work. But yes, with these, and especially because these devices, definitely I want to encourage the patient to take home with them. This is yours, you paid for it, might as well take it, stick it in the drawer, clean it. If next year you get that same heaviness, that same chest cold, hey, this is yours, why don't you use it? And like I said, in lab Friday, you'll see these things. If you know how to search, guess what you can come across on Amazon? If you know how to search, got to use some of the right words. And guess what? For some of these things, you don't need a prescription. So, and I've shared this with students in the past going, man, this really helps, John. All right, but you can't take mine. That one's mine. But if you go check Amazon, where do you think I got half the stuff we have in there? You know, if you know what to search for, if you know what you're looking for. And again, I've seen some of these things on here. Remember I said this was like a $200, $250 item? $20 on Amazon today. Like, wow, where was that? Made by a different company, different manufacturer, whatever the case. But again, there's stuff on there that, you know, whether it's for you or a friend or family member that says, man, is there anything I can do? I mean, if they're sick, send them to the doctor, make them see a professional. But if something else could help with kind of mucus production, mucus elimination, you know, these are easy. These are simple and fairly inexpensive, at least from what we can find, say, on Amazon. All right, a few other devices. Now, these are moving up in complexity here. These are not the easy PEP adjunct type devices. So the intrapulmonary percussive ventilation, IPV for short, or the MetaNet. Now these are, yes, go ahead. What'd you find?
I found it.
Yep, yeah, $20, right?
23 bucks.
Comes with 3 different, and again, I have no stake in this, but if you find Salazar store, just, I'm kidding. I'm kidding, camera, all right. Chad, you'll take that out for me, right? I appreciate it. But in IPV or the MetaNeb, these are very specific brands of devices that can provide high frequency positive airway pressure. Again, mechanisms, things to aid with airway clearance. So both of them, notice the second word. So what powers them? Air. Gas, compressed gas. It could be air, it could be oxygen, but compressed gas. So these things you wouldn't necessarily find in the home. Again, it's not electricity. It does require a pneumatic gas source. But the IPV delivers a rapid series of pressurized gas mini bursts to the airway at very fast cycles per minute. MetaNeb, high frequency rates, oscillatory percussive breaths during inspiration and expiration, and resistance levels on exhalation. And these rates, notice, again, very similar, very fast. Very fast. So this is not a breath in, breath out type device. Wait a few seconds, breath in, breath out type device. Because look how frequently they're cycling. The IPV, patient inhales and exhales through the device as the oscillatory pressure is applied. Now the picture I've given you here happens to use a mask. This could be with a mouthpiece, it could be attached to a trach, it could even be attached to an endotracheal tube. Again, I just happen to pick this particular picture. Patients tend to tolerate this fairly well. An alternative type of airway clearance therapy, if the patient can't do what? Take a deep breath in. Again, me making GIFs here, sorry. Notice how fast and how rapid these little mini breaths are. I can't wait till Friday. You actually get to see this being applied. Being applied, right? Does that look familiar to you? All right.
Is that almost like the oscillator, or?
It's the same concept. Oscillator is something that's very, very rapid, very, very fast, just like this is. Just like this is. All right, so a few settings here. Okay, a few settings. There's the frequency setting that determines how fast, how frequent these breaths are going to go. And remember, they're fast. They're very fast. If you can see the dial here, here's the frequency dial. So you can adjust this fast, you can adjust this slow. That's how quickly or slowly the breaths are going to be applied. The amplitude, that's the big dial here on the right. That controls the amount of pressure, or maybe the size of the breath, without calling it a tidal volume breath, because it's not the same thing. But if you want them, and again, remember, this is very rapid, do you want more air movement or less air movement? You can adjust that with the amplitude. It has a gas source control. You can turn it to O2, you can turn it to air. There's connections on the back, so this can get plugged into both oxygen and air outlets. And you can turn it back and forth, whichever compressed gas source you want to use. Oxygen, maybe if my patient requires O2, then maybe I want to run it through O2. If it's one of you guys that don't need O2, then I'd probably just run it through regular room air. Digital display, that's what is here. Kind of zoom in. All right, so reads the mean airway pressure, which is the average airway pressure. Tells us the pulse frequency. Remember I said this device provides very, very rapid breath. So that's the frequency. I'm not calling it a respiratory rate, but that's how frequently it's going to cycle. Right now it's showing 247. The amplitude is this number here. And again, I cheat when I do this. Notice this little window here because it's kind of showing size. I'm going to bounce back a picture here. Notice this one shows size of the breath. That's what this is showing. This one is frequency, which if you notice that same symbol. Now I don't know why. If I was designing this, I would flip-flop them so that amplitude would be correct and the frequency would be on the same side, but nobody asked me my opinion on that. And then the last part is time. So once the therapy starts, this clock starts. So you can kind of see how long they've been performing this therapy. Has it been 10 minutes, 20 minutes, 30 minutes? How long has the therapy been going on for? All right, but IPV. The MetaNeb, very I'm sorry, go ahead.
With doing this, because you're like with suction and stuff like that, you're kind of like taking away oxygen, like.
Well, it's not pulling per se like the MIE is pulling that stuff out. This is just going in and out so fast, so rapidly. For you and I, we could handle it. We wouldn't need any extra O2. But if my patient was on oxygen, you know, around the clock, then probably I could run it through O2. Again, during all these therapies, I'm still going to monitor the patient throughout. I'm still going to keep an eye on what their pulse oximeter sat is. And if it was 95 when we got started and now it's 91, all right, I'm going to make sure I flip it and make sure if I wasn't running on O2, that I am running on O2.
So how you said it was like pulling in and out, this is like what you were like saying when it's like an inside vibration, right? Like
Yes,
that
yes,
is what that
it is,
Okay.
it is. Whereas the PEP or oscillatory or vibrating PEP therapy required me to exhale through the device. This one's doing it, whether I want it or not. The MetaNeb is a very similar type of technology, but made by a competing manufacturer, a competitive company. That has a couple of settings, couple controls here, the CHFO and CPEP. Creates positive expiratory pressure. I'm not calling it IPPB, but IPPB-like, in that there's expiratory pressure being applied, and then the oscillation. All right, so the air going back and forth. And so we could actually, depending where I turn this dial, flip-flop back and forth between expiratory pressure the patient's going to feel back to oscillation that the patient would feel. I can still make adjustments to control those pressures or those oscillations faster or slower, just depending what my patient needs. Plus, and the same thing I forgot to point out with IPV, you can still, they both have nebulizers, so you can still provide nebulizer therapy throughout the therapy. This one, if you wanted to, you could just set it to aerosol or nebulize only, but then that defeats the purpose of this device. Why not just use a regular nebulizer? But maybe they want to have a break time, but they still need to receive their medication. Okay, I could use that as a break time, and then go back to the various pressures. Now, what the manufacturer says with this is the treatment should take about 10 minutes. And if you notice, 2.5 minutes with that positive expiratory pressure, followed by 2.5 minutes of the high frequency oscillation, followed by another 2.5 minutes of pressure, and then another 2.5 minutes of oscillation. 10-minute total treatment time. Again, but why are we doing this again? Airway clearance. Airway clearance. Just another means to provide airway clearance therapy to a patient. And you won't see these at every single hospital. Some have them, or some hospitals have one type. Another hospital doesn't have that type, but they have the other type. Okay, so it just depends on the facility. And then some of them, to be honest, don't have either one. Okay, it just depends on the facility and what we have available to us. All right, last thing, so high frequency chest wall oscillation compression, or chest wall compression. All right, these are oscillatory devices. So oscillatory meaning this energy is going to oscillate or vibrate back and forth. Now usually they require some sort of variable air pulse generator, so a machine or something that's going to create this air energy, and then some sort of vest or wrap that will stretch around the patient's thorax, stretch around the patient's chest wall. There's different brands, and just like my Kleenex analogy, the vest was the first one. They trademarked that name, and I can't help it. Every one of these, even the other types and other brands, I still call them all the vest, and that's not right. It's not true. Puff's company would be really mad at me if I kept calling this Kleenex, right? But they all work, they all do fundamentally the same thing. How they get there, and there's been improvements on design over the years, don't get me wrong, and there's some that are probably way better than the other for various reasons, and you'll kind of see what some of those reasons are shortly, but they still provide the same sort of therapy. So the air pulse generator inflates and deflates the vest that is surrounding the patient's chest wall, or wrap that's surrounding the patient's chest wall, creating a pressure against the thorax, causing chest wall oscillation and movement of secretions forward. So it is a wrap or a vest that goes around the thorax. It inflates, so what does that mean? That vest or wrap squeezes the chest wall, hugs it tight, and that's okay. You're gonna see what it feels like. And then that tightness, that squeeze, then can oscillate. And picture a vest wrapped around your chest right now that's doing one of these. That doesn't get tired like you and I get tired doing manual CPT. Doesn't require patient positioning. Doesn't require postural drainage. So my patient who can't handle being placed head down in some crazy position and you beating on their back, no. They can wear this, sit upright, sit comfortably, sit in a chair, read a book, play on the computer, watch TV, play on their phone, play video games. Doesn't matter. They can do all of that while they're still wearing the vest and still receiving the therapy. So different types, different examples. The vest, again, is probably the popular one just because it was the first, but there's others that are out there. So the vest does come as a single unit, can be placed on kind of a rolling cart. This young lady's wearing the vest while she's doing what? Taking her nebulizer treatment, her medication. Here's the wrap. So that one is a form of the vest, but it's a wrap, a non-disposable type wrap. This one, I believe, is the Cough Assist. Their improved design. It requires a single hose, where the vest requires 2 hoses. Okay, improved design. Okay, less circuits to have to mess with. The Aflo vest has no separate air pulse generator, no circuit. It's its own entity. It's all created here within the vest itself. Plus, the added advantage this one has over the others, it's portable. It runs off of a battery, a rechargeable battery. So I could be wearing one right now and walk all around this room and still get my therapy and lecture to you guys. As opposed to if it was the vest, I have to be plugged into an outlet somewhere, and I can only go as far as the circuit and the power cord would let me. All right, so again, depending on who the patient is. You know, if I'm looking for portability, maneuverability for my patient does a lot of travel, moves places to places all throughout the day, maybe their job, but they still need this therapy. And maybe something that doesn't require electricity, doesn't require this big bulky device to go around, maybe something like this would work. Don't ask me how long that battery lasts, but I'm sure it lasts long enough. And again, it's rechargeable. I'm not having to wear this all day long, only during therapy, so even in between I can recharge that battery. All right, questions on the?
It's probably more expensive.
Yeah, that's a good question. I didn't pay attention so much to cost, but yeah, that's always a consideration. And covered by insurance? Maybe, maybe not. But maybe the insurance will say, well, we'll pay for this one and not that one. Okay, so there's going to be some limitations depending. And again, it all, I'm sure, relates to cost.
Because they're medical professionals.
Exactly. It drives me crazy. Yeah. Yeah. All right, any questions on the vest? And I hate to call it that because the vest is a brand name. But saying the vest is better than calling it a high-frequency chest wall oscillation therapy vest. I'm good with vest too. Okay. So what I've given you here is the popular one. These can be used in the home. These, of course, can be used in the hospital. This is the vest air pulse generator itself. Very few controls to have to really deal with. There's an on-off button on either side. This controls the hertz or the frequency. How fast do you want it to shake? Now, you can put it pretty low where it's just doing one of these, or you can make it really fast. This number here in the middle controls how tight or how much squeeze the vest has around the patient's chest. And then the last one is simply a timer. And so you can see minutes here. So you can set it for the timer. And that's it. Now, therapy can be performed for 30 minutes, 2 to 6 times per day. This is very popular with the cystic fibrosis patient population. Again, they may have started with some manual CPT, but as soon as mom and dad said there's a what? Oh, okay, let's try this. This is so much easier. And again, the child could wear this when they're old enough. They could wear it, still watch TV, still play video games, still play on their computer, their phone, do whatever, and still receive therapy. Therapy is done at oscillating frequencies between 5 and 25 hertz. Okay. Now, a hertz might not mean anything to you, but just so you can see the comparison, 1 hertz equals 60 cycles a minute. So help me with the math here. So if 1 hertz equals 60 cycles, then 5 hertz means how frequently is this thing vibrating? 300 times a minute. That's at the low end. I'm gonna need too many fingers and toes here to count, but at 25 hertz, 25 times 60 is,
That's like 750.
that's more, I think it's more than that. 1200, something like that. I don't know, we can figure it out later. But at extremely fast vibrating frequencies or oscillatory frequencies here. Yeah, this one's 300 cycles a minute, this one's 1500 cycles a minute, meaning how fast it's doing this, right? 1500 times a minute, so extremely fast. Should be set to the highest level that's comfortable for the patient. Again, this shouldn't be a therapy that hurts or is uncomfortable for the patient. Some patients can handle higher frequencies than others. Some patients can handle higher pressures, higher squeeze than others. But it's a matter of just finding that fine line. Again, whatever the amount is that's provided should be enough to make sure it's working and it's helping the patient clear mucus, clear secretions. Questions? What patient population do you think this could be used for? Cystic fibrosis, yes. Elderly only.
Kids too.
Kids too. Young kids, sure. It could be used on young kids as well. Speaking of which,
He's like, oh, this is a nice roller
he
coaster.
doesn't have a care in the world, right? Why y'all get this camera on me? Take it away. Shaking that mucus. Shaking that mucus. And again, you don't have to put them in any postural drainage position. This needs to be your first patient that gets to wear the vest from you, right? All right. We've already talked about this, but making sure the patient does mobilize, that's only going to help aid in secretion clearance. Even for that intubated patient on the ventilator, I don't know where the ventilator is, but who's on the ventilator, notice they're tailing him with the wheelchair, just in case. Again, I'm not expecting him to go very far, but adding this to any of the airway clearance therapies we've talked about already is only going to benefit the patient and improve the patient's overall ability to clear secretions. So, when we are performing airway clearance, things to assess, so outcome assessment, we should see a change in sputum production. I don't want sputum production to go down. I want to see sputum production improve. I do want to see airway clearance. If it goes down, then maybe the therapy's not working. I should hear clearer breath sounds. If they were had breath sounds that were really wet, really roncorous before, I should hopefully hear some of those sounds lessen and more clear breath sounds if the therapy's working. The patient's subjective response to therapy, they should tell us, yes, I feel so much better after receiving this therapy. Might not have happened the moment they performed it, but over time, some of these therapies, we may be going back into patients' rooms 4, 5, 6 times throughout the day, having them perform this therapy again. Like I said, we will see hopefully, and the patient can tell us how much better they feel after receiving that therapy. And it may have taken several cycles of that therapy before they start to notice it and be able to mobilize secretions. Change in their vital signs, so hopefully, again, if the reason they were so tachypnic was because they had so many secretions, if I'm getting rid of that stuff, hopefully their respiratory rate's coming down. Their chest x-ray should improve. Their ABG results should improve. O2 sac should improve. Again, if this is working, we're getting rid of those secretions. If they're on the ventilator, there are certain things we can notice on the ventilator that can let us know that airway clearance is actually less. Just because a patient was ordered this on their admission today doesn't mean we're going to continue that therapy the next week or the next 2 weeks. So the patient should be reevaluated to see if this is working, if there's benefit. And at some point, perhaps the therapy did work, it did its job, and now the therapy can be discontinued because it was working. And so a hospitalized patient should be reevaluated every couple of days, 2 or 3 days, to see if therapy needs to continue, or if maybe therapy needs to be advanced, or maybe this therapy wasn't working because they were prescribed the flutter valve and they just can't perform that device correctly. Maybe something else like the vest could be transitioned to. If it's a home care patient, every 2 to 3 days is not realistic, but maybe every three months or so to be reevaluated to see if therapy is still necessary. Now, I do know in certain chronic conditions like cystic fibrosis, for example, that therapy is probably never going to go away, but they still will have to be reevaluated to make sure it's still working, that therapy that was selected is still doing its job. Because again, there's more than one type of airway clearance therapy. There's a whole bunch when you look at the big picture. That was the last slide. Questions? Who wants to wear the vest? Good. Remember that come Friday. You're wearing the vest too, okay? I saw your hand. No, you want his hand was up. I just saw it. Busted.
No, I know we're gonna learn about disease process
Yep.
and things like that and when to use it, but are we gonna talk also about like cognitive delayed patients, things like that? Cause like my daughter, for example, she uses the vest every day, but not because of disease process itself, because she's severe
Aging.
cognitive delayed. So
Gotcha.
if she's sick or not, I don't even know if she's getting, so it's just to prevent secretions to be sitting there, cause she doesn't follow instructions.
Right, gotcha.
So that affects, sometimes you have patients that just.
Yep, absolutely. And again, in that example, simply is preventative.
Yeah.
Prevent secretions from having a chance to accumulate or build up over time. Yep. So yeah, we'll talk more about that kind of in some of the disease processes, where this type of therapy would be used. All right, any other questions before I give you mine? I think I have 3 or 4 today. All right. PEP devices typically generate what expiratory pressures? 5 to 10, 10 to 20, 20 to 25, or 30 to 50 centimeters of water? What do you think? PEP devices typically generate 10 to 20 positive expiratory pressure devices like the flutter valve, the Aerobica, the Acapella, the VibraPep, TheraPep, the PepPep. All right, 10 to 20. Now, PEP devices, if you're thinking, well, what about like the IPV or the Medanev, MIE, that's different. Those aren't classified as PEP devices. So be careful. These devices are those more handheld adjunct type devices like the flutter valve or Acapella or Aerobica. All right, so this one is B, 10 to 20. Next question, which patient population most commonly benefits from MIE therapy? MIE stands for mechanical insufflation, exsufflation. I know. Insufflation, exsufflation. COPD patients, asthma patients, cystic fibrosis patients, neuromuscular disease patients. D, neuromuscular disease patients. They most typically benefit. So if you happen to work in a facility that sees lots of neuromuscular disease type patients, the chances of you seeing an MIE type therapy is going to be higher.
Like an RICU maybe?
What's that?
Like an RICU maybe?
Maybe. Yep. All right, so this one was D. Next one. Used to it. Every wrong answer, I'm still putting COPD on there. Wrong or right answer, I'm still putting COPD on there. All right, next question. What's the name of this mucus clearance device? Is this the flutter valve, Aerobica, VibraPep, the vest, or Acapella?
The best.
Jeremy says it's the vest. Thank you for the praise. All right, so what is this one?
Flutter valve.
This one's the flutter valve. What's inside of this?
Metal ball.
That metal ball, that steel ball bearing that vibrates back and forth. All right, so if this is the flutter valve, then this is the, I had to cover the name because it was too clear.
The blue bar.
The blue one. All right, so this is this aerobica? This one's the acapella. I didn't show you guys this earlier. There's a green one and a blue acapella. The difference between the two of them is the blue one runs at less pressure than the green. Now, you may be in a hospital where you see both in a drawer or in a bin, you know, which one do I grab? Or you may be in a place where they only have one type. The green one carries higher pressure, so it does require, you know, it would probably work better for an adult, the green. The blue one may be more for your pediatric patient because it doesn't require as much effort. But again, if you're trying to maximize airway clearance and I had the option, I'm probably picking the green one because that would provide more therapy, but it would require greater patient effort to get it to work right.
Ours is like a light blue with a little bit of white on the bottom. Is that, do you remember? I don't know. The ones we carry that I've seen, they're like light blue on the top portion. And
Are they the acapella?
Yeah.
Next time you see it, take a picture of it for me. I want to get some of that. All right, it could be the blue one. Maybe they just add some white on the bottom. That's a good question. I don't know. But yeah, next time you see it, snap a picture of it for me. All right, any questions on any of these? Because that was my last question. How many was that? 3 or 4? 3. That was 4. That was 4.
That was
Yeah,
4.
that's 4. I'm losing my mind now. All right. Any questions? Any questions? So since we have some time, and